Our next segment is a panel discussion on mitigating the downstream crisis, caring for children while they board. Each of the organizations on this panel have implemented initiatives aimed directly at addressing the current behavioral health boarding crisis. Dr. Chase Samsel is the medical director of the psychiatry consultation services at Boston Children's Hospital. Matt Stone, the executive director of Youth Villages, Massachusetts and New Hampshire. Dr. Bruce Waslick is the chief of child and adolescent psychiatry at Baystate Medical Center. And I'd like to introduce Leigh Simons Youmans, who is MHA's senior director of healthcare policy, who would moderate this panel. So I invite you all to come up.
Thank you, Jackie. Very much looking forward to this panel. I think as both Steve and Dr. Churchwell mentioned previously, you know, we today want to focus looking forward and upstream, but we want to start today laying the groundwork of what's happening now in terms of boarding and in our hospitals addressing that boarding. And I would be remiss if didn't note, you know, boarding has been an issue even prior to the pandemic, and of course the state has led massive efforts to address it, and in particular want to note Dr. Sanders here today, who I think probably has done more than anyone else, I'll say, in this room in this Commonwealth in terms of gaining access for children who are boarding. So thank you to her for leading that work. And I did, just to note one data point before we get into it. Looking at Dr. Sanders' data, the time frame's a little different, but just to note, in February of 2020. There were 154 children were escalated to DMH after boarding for longer than 96 hours at that point. The timeframes changed. Now kids get escalated to her team at 48 hours. But in February of this year, there were 761 children that got escalated to DMH after boarding for more than 60 hours. So we went from 154 in February of 2020 to 761 in February of 2022. It's drastic. So I'll stop talking now. I want to turn it over to our panel. And this panel we're going to do a little bit differently than the others today. Each of our panelists is going to present about the work that they're currently doing in their facilities and their programs to care for kids while they board. And we'll start with Dr. Samsel. And if you could start with your work at Boston Children's. Would you like to come up here? Yes.
Thank you. Can everyone hear me okay? All right. Happy to be here today and talk a little bit about an initiative that we've developed on our medical floors, where I'm the medical director for our psychiatry consult service. I think a little bit of framing and reminding, I think it's something I repeat all the time whenever I'm talking to folks outside of Boston Children's Hospital when we're advocating liaisoning. I think one of the more rare things that we do at Boston Children's Hospital is we take a lot of kids and we board them on the medical floor, not just in our ERs, both I think because of volume, but also because of some of the things we feel like we can do during this crisis. And we're going to talk a little bit about how we've tried to develop some more specialization, some more support, and some more treatment around that today. We're familiar with the term boarding, psychiatric boarder. I think I try to use in my language as much as possible when talking with patients and families, that we have patients who are boarding, that they are not boarders themselves. It's not their fault. And also, I know this is a phraseology we can and should use to be able to work a little bit more quickly today and think about these things through the rest of the conference. I know a lot of folks have put up numbers. I think Mr. Walsh, Dr. Churchwell, these are right. Our numbers are up, right? Our volume is up. But I think it's also critical, and today as a psychiatrist, for me to reflect over the past many years that our acuity is up too. There's not a perfect number for that. But just to say, kids who used to come to our hospital and were feeling really distressed or agitated are coming suicidal. and kids who are coming suicidal in the past, who maybe were, not wanting to really kill themselves but wish they weren't alive, are now, as we say, actively suicidal. They want to die. And kids who used to come to our hospital ER in the past, who were actively suicidal but didn't really have any plans, are now coming with plans. And the kids who are coming in the past who had plans and were suicidal and maybe took an overdose or attempted to take their life are now coming in with much more significant overdoses and suicide attempts. And there really is not a perfect way to describe this, but I think we do see this somewhat in our numbers when we are talking about lengths of stay and when kids are here longer. So just briefly looking at our service, I'm not going to get a deep dive in trends, but just to see over year, right? You all know this, preaching to you, the choir in this regards, but it's not just a pandemic. We have been seeing these trends year over year for the past decade, almost every single year on my consult service on the medical floors. We have seen 10% more boarders every single year. So as Dr. Churchwell said, yes, in the past 4 years, 61% more. But if we want to talk, when I first started Boston Children's Hospital almost 10 years ago, it's double. It's double the number of kids. As a consult service on the medical floors, I used to see kids who were there for some sort of medical illness, and they had behavioral health needs that we could support them through. And now I'm seeing kids whose primary reason for being in the medical hospital is because of their behavioral health needs, and there's nowhere in the community that can support them well enough, or they haven't been able to find it. And these length of stays have been the same too. It's just getting longer and longer, waiting for more beds, bed shortages, but also acuity. So many places in the community that used to be able to handle kids that were agitated, or kids that needed a one-to-one, or kids that had diabetes or some other medical complexity have been saying we can't do that anymore. We read our capacity. So that means the intensity of kids who are continuing to board have higher and higher needs and more demands in settings that are not behavioral health primary environments, that are medical settings where people are even less trained to do those things. So some of the things that we've been doing in general over the past couple of years that have been really helpful to try to do as best as we can, right? We've turned our rooms into as safe rooms as possible, where we have kids who have impulses to hurt themselves or who are taking out their frustrations and don't have impulse control are going to hurt themselves less. Medical settings are not a great, safe environment for kids with a lot of behavioral health needs, and we see this all the time. We've been doing simulations with pediatric nursing staff whenever we have kids, for example, with moderate severe autism who have lots of different approaches with communication, intervention that they need, and our pediatric nursing staff love this. They think it's super, super helpful, and yet they remain pediatric nurses. They did not train to be psychiatric nurses. We have had power plans, lots of things we've talked about with our pediatric colleagues who didn't train in primary behavioral health, but trying to automate as many things as possible so that we're having as quality improvement, as consistent of care, and that we're guiding them, right? There's not enough of us psychiatrists, psychologists, social workers, psychiatric nurses, but we're trying to template things so that people do as well as possible during this crisis. We talked about safe rooms, but we're thinking about all the different appropriate care observers and constant patient observers too. We've talked about huddles. We're trying to huddle with all the different nurses, and we have these every single day where we're huddling multiple times a day with different entities in our hospital, trying to game plan, trying to think where are the gaps, what are the problems we're having, is there enough situational awareness, who can we advocate to? But I think we're also been huddling with some of our groups of pediatricians and nurses in a treatment manner too, not just a one-to-one, I'm gonna see each patient, but how can we get together and brainstorm in ways that are useful? We have behavioral health support plans, alerts that come up in our medical record to be able to notify, and that our psychiatric nurses, our psychologists, our child life specialists, our psychiatrists, everyone can contribute to this to give people a heads up. Maybe this is the first time you're interfacing. Maybe you're a traveling nurse and you're not used to working at Boston Children's Hospital and don't know some of our norms. Maybe you're a volunteer and you're coming in to do some art where you're able to find out a little bit, or like, ooh, don't say these words with this patient. This is actually going to be harmful. Or here's some different ways to position yourself in the room that's not going to be overwhelming to this kid with complex trauma. So we have an embarrassment of riches in some ways, and I want to keep saying it's not enough, it's not sufficient, this is not fixing the problem. But we've had a lot of folks working together, and we've tried to do these huddles, but it led us to think about how can we implement and innovate this even more. And so we started thinking about cohorting a while ago, and we've been developing this over the past 2 years, and that's what I'm primarily here to talk about today in terms of our innovation. So we have a hospitalist team now, which exclusively works with kids who are boarding for psychiatric level of care. Hospitalists who rotate from week to week, and we're going to be taking care of these kids. We have a lot of team meetings. We have a lot of family meetings. We need our pediatric hospice colleagues to partner with and to be available to speak to those things. But not just the pediatric attending, we have 2 pediatric nurse practitioners, both of which who have had a lot of work in different psychiatric settings around the Commonwealth, and they're there all the time. They're continuity providers that are excellent at being able to attend to and remember and coordinate and help support and treat some of the patients we're working with, and to have the same face time. And just to talk a little bit about cohorting, it's not just about the care we're delivering on a day-to-day basis. I think we need to think, and we have seen this has increased the overall working knowledge and specialization of our pediatric nursing and hospitalist colleagues about the care they deliver. When these families are coming in and they used to get questions about what's going on, it's like, I don't know, talk to psychiatry. And now they're able to be our partners, right? We're able to use a lot of different family education sheets, things that can empower them to work with. And instead of holding the sheet and talking about whatever's on the sheet, now they're getting better and better and they know it by heart. And they're talking about and nosing things and telling us as the psychiatry team before we even meet the patient that day, what are some things we can be helpful with for these families. We have it on the same ward, so it's actually cohorted. This is not a psychiatric unit. Kind of feels like it, but it's not a psychiatric unit. There are other kids with different behavioral health needs on the unit who are not being followed by us. There are plenty of other kids who are there for pediatric medical admissions who don't see any of us, but it is in the same area. And this affords us some opportunities with all the bedside nurses on this ward, increasing their working knowledge, their familiarity, and their consistency as well, too. So we're getting increased behavioral health training for these nurses. They're really hungry for it. They want it. It's been so many years. And I think any sense of like, this is not our problem anymore, went by the wayside a long time ago. It's everybody's problem. They recognize it. We're having increased utilization, too, of the folks who are skilled and using some of those skills and interventions. We have our behavioral response team psychiatric nurses. Again, one of our niceties and innovations we've had over the past 9 years at Boston Children's Hospital. These are psychiatric nurses who've worked on inpatient psych units, and now we've started to have a couple of inpatient milieu counselors who've worked there before. And so we're having one psychiatric behavioral response nurse who's hovering around these 12 to 14 patients, and the milieu counselors going in and out of the room to have more stuff around, not just sitting there, right? We've been delivering treatment as social workers, psychologists, and psychiatrists for a while, and now this is taking it to a different level and really trying to help treat, but also hopefully helping to improve the flow, right? When people go to inpatient units, maybe they don't need to stay as long after a long wait because they've actually received treatment. Maybe they've waited for 3 weeks on the floors, but we've been able to deliver even more treatment. We can divert them now to a program out in the community. Child Life program. Child Life has always been an excellent ally of ours for kids and for families. And now we've gotten their help in doing some group programming. I'm not saying this is a PhD level psychologist who's here doing intense DBT therapy necessarily, but I'm talking about lots of programming. We have some of our inpatient unit programming where we've been able to have some advisement. What are they running? Can we have some of our artists and residents who are coming through to do some therapeutic art groups? Can we have some folks, some of our behavioral nursing staff who are coming through to do some psychiatric exploration? Are we going to do some yoga, some things that are helpful? One time a week may not seem a lot, but it's a heck of a lot than we used to do, and most places are fortunate having. And then that milieu, just talking about it. I want to talk about how not just, as I did, that the milieu therapists are useful for the kids, but they're useful for the pediatric staff, the nursing staff, the hospitalists, and empowering them to do better. So we've been talking about the system and what we're fixing on. We've had Band-Aids for a long time. This is still a Band-Aid. It's maybe a lot of Band-Aids, more complex Band-Aids. This is still a Band-Aid, right? Talking about the evolution of my service and what we're doing, this is not the fix, this is not the solution. This is what we need to do or should be doing or trying to do. I think it is better. It is not the solution to the boarding crisis. It is not fixing everything. It's not like we're getting paid like an inpatient psych unit. We're just doing these things because we need to and we have to, and we're trying something. But I think it's a good Band-Aid, and I'm interested to see where it goes. Hopefully we're going to continue to do more of it. Hopefully there'll be partners in the community that want to do similar things like we're doing. But I'm glad and I'm proud of it. And as much as it's been helpful, I can attest to it as a child psychiatrist doing this work for 10 years here at Children's, it's really not enough. Thank you.
Thank you, Dr. Samsel. Now we'll turn from Boston to Springfield. Dr. Waslick, if you could speak about your work at Baystate. Thank you.
All right, I'm really glad to be here. I'm the Chief of Child Psychiatry at Baystate. I'm a Western Mass native, UMass Amherst graduate, so I have a lot of investment in the state of mental health and in children, and especially in Western Massachusetts. Just to remind people that we do have a children's hospital out in the west part of the state at Baystate Medical Center, and a lot of the challenges that we're dealing with in the western part of the state are similar throughout the state, and it's interesting, some of the solutions, to hear Dr. Samsel's work, we've come up with some solutions on our own, and so we'll share those. And let me just make sure. So really, I'm going to address the different strategies. So I'm going to talk about adding new resources, which we've done over the past couple of years, developing new models of care, and then also enhancements to our current models of care. That's been our basic strategy. And future plans continue to add more resources if we can get them, and then further revising models of care. Those are some of the major approaches that we've had. So in terms of adding new resources, we've piloted a couple of different strategies. One was we opened up a separate space in the hospital. We called it PO2, which is the Psychiatric Observation Treatment Unit. And this was a separate space in the hospital for kids who are boarding, who are awaiting placement, and they are probably lower on the level of acuity needs, so they could be managed in a relatively low patient to staff ratio. Kids who may be suicidal, came into the hospital suicidal, need inpatient care. They're not acting out, they're not really dangerous, but they could be managed in a separate space by a relatively low number of nurses. We've called it the PDPO2, the Pediatric Psychiatry Observation Treatment Unit. They're managed from a medical standpoint by the pediatric hospitalists, and the nursing staff is provided either on the psychiatric side or through the emergency room. So we've experimented with that, and that's been a flex unit. It's opened, it's closed, it's been utilized, underutilized. But it's something that we tried. In April of 2021. We added a new inpatient psychiatric unit at Baystate Medical Center in our main campus. The last remaining beds in Western Massachusetts were at the old Providence Hospital, which closed essentially all of their psychiatric beds, but also all their pediatric psychiatric beds in July of 2020. So for a period of time, we had no beds in Western Mass for acute psychiatry. Because of different sort of initiatives and supported by the state, we opened up a new child psychiatry unit. We call it CAP2. That opened in April of 2021. It's been really great. It's been really helpful. It's been incredibly difficult to staff. When we get into sort of staffing issues, we are open for 12 beds, but currently we can only staff 6 beds because of nursing shortages, therapist shortages, and so and that's been sort of the issue with CAP2. It's great having 12 beds, but 6 of them are offline because we don't have staffing abilities. And I do want to make sure that when people understand the term boarding, we talk about boarding in the pediatric hospitals and emergency rooms, but there's boarding going on psychiatry units, and there's boarding on medical units that are not kids waiting for psychiatric placement. They're waiting for residential programs, or they're waiting for acute facilities because they're in the custody of the Department of Children and Families. So we have had kids board on CAP2 for 4 months. Their acute psychiatric needs were done within 4 weeks, but they didn't have a placement in DCF. So that, again, when you have a 4-month boarder on an inpatient psychiatry unit who's boarding, who doesn't necessarily need to be there, that's backing up the whole system, because in those 3 extra months, we could have turned over, 5, 6, 7 acute psychiatric patients. So when we talk about boarding, boarding to me is sort of, it's like the fever, but it's not the problem. There's underlying problems. There's a lot of pathways to people boarding on units for a lot of different reasons. In terms of staffing, in terms of the service that we have, which is analogous to Dr. Samsel's, we've actually added more and more staffing resources. So we've added half-time child psychologists to our service. We've added child fellows in Western Massachusetts to the service. We added a full-time social worker in August of 2021, and we added to this service to kind of care for the kids who are boarding in the pediatric emergency room or on the children's medical floors. We've also added a full-time psychiatric APRN. And it's been great adding these resources, but it's still, I mean, Dr. Samsel probably feels no matter how much you add, it's still not enough because they're doing a better job. More people actually come because they're experiencing the services they're getting, and it just expands the needs. And part of what I think we're seeing at Baystate, I don't know if we're seeing it at Children's, is that because people are doing a better job, more and people are coming because they're getting access to services through those supports. It's not just services are closed. I think people are trying to get access to services now through these type of different arrangements we've developed. The goals of the additional staffing is really threefold. One is to enhance the care of the kids in the boarding situations. We got to care for these kids. We got to make sure they're safe. We got to take care of them. We got to take care of their needs. The second goal of addition is to try to help facilitate kids moving to the next level of care, whether it's inpatient psychiatry or whether it's back to the community into community-based resources. And the third, which we've been dealing with, we've had to do, I'm sure Dr. Samsel has as well, is occasionally provide active care in the medical setting to try to divert kids from going to higher levels of care. You know, providing a meaningful care experience so that kids who came into the hospital needing acute psychiatric care don't need it and can go to a lower level of care. And we've been working a lot with that. We've had one kid, I don't know if Dr. Samsel has done this, but on their service, we had one kid who was boarding on our unit, couldn't get placed into a psychiatric unit. We actually did ECT while they were boarding on the medical service for the first time in the history of the hospital because the kid was so severely depressed. They got a course of ECT while they were boarding on the Children's Hospital. So these are the different types of solutions that we do. And additional models of care. So I was thinking of the cohorting that Dr. Samsel, we've actually done a little bit different. We've gone to a co-management type of care where the psychiatric attending team is actually managing the kids Monday through Friday from 8 to 5 with kids who are boarding either in the pediatric ED or on the medical service, and then they're shifting off to the pediatric coverage for nighttime because we don't have 24-hour-a-day coverage for our psychiatric team. So we've developed this co-management service. We've been running it now for a year where we offload the work of the boarding patients with psychiatric needs off the pediatric hospitalists for 40 hours during the week. It shifts back to them during the nighttime and during the weekend. And then we try to do as much as we can during those regular hours. So the co-management service, a little bit different than the cohorting service, but probably with the same goal. And then we've moved to, similar to, I think, Dr. Samsel's, we've done daily multidisciplinary rounding for all kids boarding in both the pediatric emergency room and on the medical floor with the child psychiatry team. So it's a multidisciplinary team. Every kid is reviewed Monday through Friday with a team plan for the weekend to try to address their needs and move the kids through the system and care for the kids while they're in the hospital as well as we can. And so we've also accessed individual resources and supports and care strategies for kids with particularly challenging issues. So we find very challenging kids with a lot of acting out behaviors. They can be very aggressive. We've had staff assaults, we've had staff injuries and things like that for kids with very severe acting out behaviors. Kids with autism and intellectual disabilities who are boarding in the hospital have a variety of specialized care needs, and they have a really, really hard time getting placed in the very limited number of developmental disabilities units that are available throughout the region. And then kids with eating disorders often need relatively specialized care plans. So in terms of future directions, Baystate is going to be opening a brand new behavioral health hospital. We're projecting in the summer of 2023 or in the fall of 2023, fall 2023, and we'll be expanding our pediatric inpatient psychiatry beds from its current 12, but we can only staff 6 of the 12 at this point, to a 24-bed unit. So we're expanding the number of child psychiatry beds, which is going to be, I think, very helpful if we can staff them. We've got to get to the staffing issues as well. We're looking at developing a pediatric emergency room annex, which is specifically for behavioral health kids, to get them out of the emergency room where all the medical work is being done, to get them into a safe, appropriate space so that they can, they can be cared for in a pediatric emergency setting, but, separated out from the kids needing medical care. And in January of 2023, we're launching the new Baystate Emergency Behavioral Health Program with additional staffing for both adults and children, requiring behavioral health support during their episode of care in the medical hospital in the emergency department. So those are some of the strategies that we've been working with out in the western part of the state, and you know, I think they've been successful, but it still feels overwhelming. We certainly haven't gotten on top of the problems that we're seeing out in the western part of the state. Thank you.
Thank you, Dr. Waslick. And so now we're going to move outside of the four walls of the hospital. Matt, you with Youth Villages, not part of hospital, but would love to hear more about your Intercept program. Thank you.
Yeah, I've never been on a panel with two doctors. I don't think I've ever been in a room with so many doctors, actually. No, it's great. I really appreciate the opportunity to talk about this. So my name is Matt Stone. I'm the Executive Director for Youth Villages. We're a national nonprofit. In New England, we're serving about 1,000 young people and families a day. We have two evidence-based models. One is for transition-age youth called LifeSet, who are young adults who are aging out of care, but we have another model called Intercept. And it's an evidence-based model. And the best way I can describe Intercept is a very highly intensive in-home family therapy, and it was designed, we've been doing this model for decades nationally, and Intercept is really designed to meet the needs of children who, without that level of intervention, they would be in some kind of out-of-home placement, residential care, group home, psychiatric placement, detention. But recently we've, over the last couple of years, been able to adapt our Intercept model to be able to help with the boarding crisis. And again, you know, we're part of the solution, and I loved what Dr. Churchwell said about let's accelerate the solutions, and you know, we're happy to be able to play a small role in that. Let's see, let me do this. So I won't go into, whoops, went the wrong way. There you go. You know, we all know the problem. I think the main takeaway I'd like you all to hear from me is that you know, we've been able to show on the right side, you know, that an evidence-based in-home intervention is an alternative pathway that can safely lead to success for youth suffering from a mental health crisis, anxiety, depression, and their families. And I think that's what we've been able to show. You know, and I think it has taken the pandemic and the crisis to really help the system find a way to fund our program across the board. But last year and a half, we've been able to prove that many of the young people who are showing up at the hospitals really don't need a bed at all if we can get them the right service and get them the right intensive in-home service. So let me jump to the core, whoops. So let me give you a little background on Intercept. So again, Intercept, it's a highly intensive in-home therapy designed to strengthen at-risk families. And generally speaking, and we tailor the model to the needs of the family, but treatment takes place, we see families at least 3 times a week, typically. The caseloads are very small per what we call specialists, but per counselor, it's about 4 to 5 families at a time. And really everything they're doing from day one is focused on safety. Safety sweeps, lock boxes, door alarms, you know, we're really there to ensure a safe environment. And we're also on call 24 hours a day. So every hour you can name on a clock, we are out there with some family helping them manage through some kind of crisis situation. In Intercept, we serve families really ranging in age from infant to 18. And, you know, it is an approach that focuses on the entire family. We might be referred a specific child, but really we treat the entire family as the client. So we started our Intercept program in Massachusetts in 2007, and our work is primarily through the Massachusetts Department of Children and Families and through the Department of Mental Health. And we had been saying fairly early on when we launched Intercept that, you know, hey, we think Intercept could be a great alternative to a lot of these children ending up in hospitals and ending up stuck in inpatient settings. But again, it really wasn't until, you know, the pandemic and the crisis that has resulted that all the pieces came aligned to be able to allow us to do that and to really give it a go. Actually, let me back up one second. So we actually were able to start using our Intercept model as a hospital diversion program in the southeast part of the state. It was actually the Department of Mental Health who approached us with some, I think it was a Samsel block grant to help us actually do that program. And we started with some hospitals down in the Southeast. We worked very closely hand in hand with DMH during that launch, but slowly over time, I think word started to spread about the success we were having with the families that we were serving, and we started to access and started working with different hospitals, started spreading into the central region, and were able to then, through the support of Secretary Sutters and the Baker-Polito administration, to really take the program statewide through DMH funding. And, essentially for Intercept, the way we've adapted our Intercept model to be able to meet the needs of these families, we are working with, I believe, about 22 hospitals across the state. And we get a call from the hospital, and they say, we have, and of course we've developed relationships, very strong working relationships with the hospital staff. They know our program very well. They know our limitations too, and we're the first to acknowledge many of the children that are, many children are not appropriate, for this kind of in-home intervention, obviously. But we will get the call from the hospital, and we will go to the hospital. Our goal is to be there and meet the family within 24 hours of the phone call. And we do an assessment, a pretty detailed assessment on the front end to determine if this is a safe intervention for the family and for the child. And then, usually we're able to discharge within 24, 48 hours of that first meeting. And we literally follow the family home from the hospital. We literally do that. And, that's when a very intensive in-home treatment begins, immediately. Again, with a very strong focus on safety sweeps, teaching the family how to look for dangerous objects in the home, depending on what the presenting issues are. Again, door alarms, lock boxes. And we're seeing the family in general in Intercept on average of 3 times a week. I will say the majority of the families we worked with in our hospital diversion work, we're seeing much more than that. Sometimes every day we're in the home, and we find a way to pull our team together to be able to do that. And again, it's providing care for these children in the home setting. We feel like that, it's part of the solution to help hospitals alleviate the boarding crisis. And what we found too is that we've had so many families who have said, they've been through this cycle again and again with their children, and it's heartbreaking. And we've had, families that have come into the program just say to us they're stunned that an intervention in home is actually available to help them be able to manage the crisis. In terms of outcomes, to date, we took our program statewide, I guess last November, so we're going on almost a year. Again, through 21 hospitals, we've served close to 200 children and their families. And again, the outcomes are really great. These are updated, I think, through the end of September. And what we've shown is for the families that we've served, 140 out of the 192, once between the time treatment started, had no suicidal ideation, no attempt, self-harming, no serious incident, or a psychiatric hospitalization during the time we served them. We measure outcomes only for families that have received at least 60 days of service. That's really the minimum dose that we would actually measure outcomes. And then the average length of stay in the program is about 144 days. But again, what we found is, I think the major takeaway for me is that the vast majority of the children that we've been able to help in this program, we were able to help them not need a bed at all. And we were able to maintain them safely at the point of discharge. Again, you can see the numbers at the bottom. 97% of the children were living at home at the time of discharge. And then you can see the other settings that they were in. But again, it's not appropriate for every child. But we think, we've got families, we've got parents who are terrified. Their child's having a behavioral health, mental health crisis. They don't know where else to go, and so they go to the ED. Where else can you get help 24 hours a day? And, the hospital relationships and actually, Dr. Waslick, Baystate has been one of our very first partner hospitals. I think our staff have gotten to know the hospital staff very well. The hospital staff now really understand how our program works. and what kinds of situations are appropriate and which ones are not. And so we're really happy to be doing this work and be partnering with hospitals. We hope to be able to expand our Intercept for Emergency Diversion program, very significantly. We're serving about 80 families per day in the program. And of course, on top of that, we're serving about 450 families through our Intercept program, through DCF and through our regular channels. But we have about 80 families in the program. But again, a lot of it goes back to workforce, our ability to expand. We'll talk about that a little bit later. But we believe we can do a lot more. And I'm just inspired to hear Dr. Churchwell and others talk about, the collaboration and innovation. And I, again, quoting Dr. Churchwell, accelerate the solutions and really coordinate and fund these solutions. And we can do so much more. I will say a lot of times it's the funding piece that has been a barrier to be able to provide this. But we're, again, very deeply appreciative of the administration and Secretary Sutters for really helping us be able to provide the program statewide. So I appreciate everybody being here and the focus on this issue, and it's such an important program for us that we're really proud over the last couple of years. So thank you.
Thank you all. And so I think what's, to me at least, most impressive in all of this is this has all kind of been built in the last 2 years, and what great programs have all been established in that time frame. So I kind of, in that vein, want to ask the three of you, they're all, this is a new venue for these services for you, Matt, but for you, Dr. Waslick and Dr. Samsel, what is it, and Matt, what will it take to sustain these programs going forward? The softball to start with. I think if you hit so that it's green.
How about there? Yeah, much better. Sustaining those programs, well, I think we have plenty of business. So I don't think that's a program. We have a summer partnership with the Justice Research Institute and partnering with TMH at Children's, and that has been invaluable. I think that we have plenty of kids that could benefit from it, more than usually staffing is allowing for. I think our big hope and worry, having seen so many different initiatives over the years, is this going to keep going on? I think it's not just how can we grow it, but is it going to keep going on? Is this a resource that's still going to be here? I think one of the things that we thought and had hoped for is that when we had kids presenting to our emergency room, that we would have this resource and could divert a lot of kids right away. And just to speak to acuity again, I think what we've noticed is that most of our kids in the ER are not ready for this type of programming yet. We actually need to do a little bit more stabilization because kids are coming to us in such high levels of distress and having so many needs, and they either need to board in our ER or medical floors for a while and get some more active treatment, and one of our psychiatrists starts some meds, we're doing some safety planning, acute planning, and then after they've been boarding for a little bit is when we found that we were most referring to these kids. And it, I think, highlights that, wow, if we could have these programs available in different ways earlier than having to wait for things to get so bad that you have to come to the emergency room because your school, your community, your parents, your guardians, your DCF placement think we have reached our limit, we can't handle it anymore. I bet that this would be able to fix a lot of the boarding process, not just getting kids out of the hospital, preventing the need to come to the hospital, hopefully preventing some of the completed suicides that happen or the agitated episodes that injure someone else or themselves.
I was gonna, can you hear me?
I think, so it's green, hit the button.
All right, green. So I was just taken by the word sustain. So sustain is not on my watchword. In some ways it is, because but we have to grow. We have to get better. We have to get more. I think the need for mental health services and supports at all levels, where it's this, the outpatient level, the subacute level, the emergency level, the inpatient level, the chronic level, is just enormous. And, we never have any issues. I'm sure Children's doesn't, and having consumers. It's just, I think we're only hitting a small part of it. And that's why I've kind of said to our folks, as we do a better and better job, we're going to get more and more people who are looking for quality care, and if they're going to get it in the emergency room, which is probably the worst place to get it, we don't want that. We want to build all the outpatient supports. We want to build the MCPAP program. We want to enlist the primary care providers and the pediatricians as part of the mental health workforce and are on this. But there is an issue with sustaining. So because like our inpatient unit, we're having trouble financially sustaining it because, we're running below projected levels. Kids are boarding for long periods of time. Once they move from an acute care episode to a boarding situation, that becomes very different in terms of finances and resources. And so inpatient care has to be sustained or grown. In our case at Baystate, we're trying to grow it, but finances could really affect things on the Baystate side. So it's really important. So I'm not thinking about sustaining. I'm thinking about growing.
I think we should also mention burnout too. I mean, sustainability here, the consult service that I run at Children's and the care that we all proud and happy to deliver all the time has had a nearly 75% turnover in the past 2.5 years. This is really hard work. It is vicariously traumatizing. It's hard to feel like the system is broken just watching these families, and then even the good and innovation you feel like you're doing, it's not enough. Families are not happy about it. They're like, great, you have some group therapy you're doing once a week, or I get to start a med, but like, why are all these things not happening? What other program in all of medicine do you come into the emergency room for and you're like, just wait here for 4 weeks and we'll get you that? Hopefully. It just doesn't happen. And I'd be curious, Matt, for you too. I mean, I think our experience with lots of in-home and diversion therapy programs is that the best and brightest usually get poached really quick, and you have tons of turnover in that setting as well, right? This is under-reimbursed. I mean, a lot of the folks who have left my service, I mean, you can work in the community in private practice and make 50%, 100% more than you're making and work half as few hours, and those hours are a lot less stressful, right? More vacation. I mean, there are so many ways in which it pools, and if we're just going to continue to rely on the altruistic nature of everyone, that's not going to get us out of this problem.
Yeah, I mean, I would just say for us, as far as our program, I think again, it's about integrating and like opening as many doorways as possible for us to be able to come in and do the assessment to determine which families or which children could be appropriate for this level for our type of intervention. Because again, yeah, clearly some kids need that time in the inpatient. But again, we've also found time and time again, families that have come into our program and have been extremely successful and be able to be home safely. And so I think it's about the funding piece, but it's also about finding flexible ways to partner with hospitals. And our relationship with every hospital is a little different, how we work with them and how it goes. But essentially, it's a trust building exercise where we come to trust the decision to bring somebody home, or when we say, okay, this is not going to be a safe situation for a child to go to. So
one thing I just want to add about Matt's program that we've been doing. One of the things that is particularly troubling is when kids have just had an inpatient stay for 2 or 3 weeks, they come out and they go home, and then all of a sudden they're back in the emergency room within 4 or 5 days. They've just had the highest, most intensive level of care that we've all been waiting. They might have been boarding, waiting for that, and they go. And it isn't like those folks necessarily need to go back to the inpatient unit. They need a program like Matt's to try to help them implement everything that they've gotten from the inpatient unit, carry it over to home. So working with the families, working on conflicts within the home, getting access to services. So this, we've had a number of kids who, come to our emergency room after an inpatient stay looking for another one. And this is, I think, particularly the role of youth villages has been very helpful for identifying those kids. You've just had the inpatient stay. We've got the psychiatric evaluation. We got the medications. But now we got to do some stuff at home to make things work out so you guys can live at home safely.
Yeah.
Thank you. I think actually, you know what, Emily, one last question, and then we'll wrap up.
I'm just wondering about what inpatient units are able to do about referring families to CBHI, in-home therapy, or the wraparound or whatever, there's, the waiting lists aren't what they used to be. There's actually open capacity. So just wondering what you do about that.
Are you talking from the medical side or from the inpatient psychiatric side? Or both? Both. Well, on the inpatient psychiatric side, if they're going to go home, they're going to go home to sort of a plan, and it often will involve the CBHI services. For kids who have mass health, there had been legislation passed a couple years ago which kind of mandated the private insurers to get up and rolling with the CBHI level of support. And in the West, I don't know how it is in the rest of the state. In the Western Mass, we keep asking about, I'm talking 2 or 3 years ago, the legislation was passed, still hasn't been implemented. We still can't get CBHI levels of support, provided by the private insurers. Is that the case throughout the state, or is that unique to Western Massachusetts? So we'd love to get more of that for the private insured kids. We can get access to that for the public insured kids, and we make use of that as a diversion if the kids can safely go home from a medical setting or when they come to the end of their inpatient stay.
Yeah, I think we've had similar challenges for our insured families, and I think we have a lot of families where they get Mass Health secondary and they're paying a lot of money a month, despite having a primary commercial insurer, but they're paying a lot of money a month for Mass Health primarily, so they can get CBHI and home services that they're just not able to either get approved or find a way to start as quick as they'd like with their commercial insurance.
I would also add, I was just going to add, I think, a lot of the families that we see, they need so much support, such intensive support. They need, the 24/7 on-call, in-person response. So I think there's some children, I would imagine, who are able to be discharged with an in-home service like a CBHI level. I think there are a lot of families who really, like to what you were saying, Dr. Waslick, who really need that higher level of in-home, 24/7, in-person support.
Absolutely, yeah. One day a week meeting and some transition plans. It's just not. Yeah. We hope it's going to fly, but
some of it has still been in Western Mass. Has been virtual. Some of the in-home therapy has been virtual, which is never as much impact as actually getting out to the kids' homes and working with the families in person.
There's no way to. I know you need to go. There's no way to teach a family how to really safely manage these kinds of behaviors through a screen on a phone or a tablet.
Thank you. I think we could all listen to you talk about these initiatives all day, but we're going to turn it back over to Jackie. Thank you all so much, folks, for being here and for your work.